Now I'd like to call Dr. ROOPASREE. She is going to talk on itching and watering in pediatric age group.
Good morning all. I thank Malik sir for giving me this opportunity and also the AIOS. Most of the things are covered by the previous speakers, and I am going to cover a little bit more about the allergic conjunctivitis mainly in children, and along with that other differential diagnosis we have to look for. There is a proverb which goes like this: no matter how many times you do it, you are always going to have an itch to do that again. That is the if there is an itch, there has to be itch. That is the richest. Itching and watering of eyes in children we are all commonly encountering in our clinical practice, and especially in pediatric age groups, kids will not complain of rubbing of eyes. We have to ask the parents whether they rub the eye or how many times a day, what time of the day, and whether it is intermittent or chronic. All these questions we have to ask from the parents, and many a times father will be accompanying and he will not be knowing most of the things, and only the caretaker, the mother or somebody else in the family who is there with the child will be knowing. Please extract that history. And the differential diagnoses are many, and the previous speaker told it may be blepharitis or some infectious or non-infectious conjunctivitis or keratitis. Why we have to worry about this itching and watering in these little children is, as we all talked about, it affects most of the children, nearly 50%. Imagine half of the pediatric population, they will be having itching eyes. And often it is underreported, leading to underestimated incidence and prevalence, and accompanies allergic rhinitis, and it's a notable comorbidity of asthma. Parents will be more worried about the rhinitis and the asthma, and when the eye symptoms become severe, they tend to come to the ophthalmologist. There is considerable impact on the patient's quality of life and comfort. For the children, the concern is corneal involvement may result in visual decline, and for the parents, it's a substantial burden on the economy through the healthcare costs and the reduction in the productivity. As we are all aware of, a lot of global warming and more carbon dioxide in the environment and the changing botanical landscapes, which is making the peak pollen season increasing. It's so increased that the peak pollen period is sometimes all through the year. What classically is described in the VKC as classification of seasonal, perennial, vernal and all, we are seeing all the time in the year because of these peak pollen seasons. And data scarcity from large-scale industries in these allergic conjunctivitis is remaining a challenge for accurate assessment and understanding of this condition, which is multifactorial and it is very difficult to understand. This I am not going to speak about because madam has already spoke about it. And the etiopathogenesis, as we all know, the mast cell degranulation and the production of IgE, this we have to note because we are going to test in the investigation part about the serum IgE levels and the TR-IgE levels. It is produced more of locally, and only in chronic cases it is seen in the serum. Coming to brief about a little bit different allergic conjunctivitis in children, the seasonal. This is the typical look of a allergic conjunctivitis child who will have little bit watering and perilimbal pigmentation and nicely opening the eye. The most common form it is, and pollen is the most common cause, which is there outdoor, and it's very often associated with rhinitis, and the cardinal symptoms signs described are tearing, itching, redness and edema. These four will be there in all allergic conjunctivitis in children. And relapse occurs regularly at the same time of the year, and lids will be usually normal. Child will be, that's why I told it will be normally opening the eye. Follicles and papillae may be present. The second one is perennial allergic conjunctivitis. Most of the symptoms last longer than 6 weeks. We are seeing nowadays longer than this period. And outdoor allergens, that is animal dander and house dust mites, are the most common cause. And usually only the conjunctiva will be involved. And sometimes in some cases we can see the corneal involvement in the form of SPKs. And in addition to these classical symptoms, note there may be lid edema. And most serious cases can have corneal involvement. Coming to vernal keratoconjunctivitis, if it's only the conjunctival involvement, we need not worry much, but if it is involving the cornea, it can cause threat to the vision. It's a severe form of allergic conjunctivitis. In children, it affects boys more than girls and first appears before the age of 10 years. And photophobia sometimes causes blepharospasm. All these are seen in the corneal involvement. And there will be disabling pruritus. The child will be rubbing the eye intensely in the class, in the outdoors, in the home, even during sleeping. That's what the mother says. And many a times the children in the hostel, the parents will not be knowing how severe the itching is. We have to assess depending on the signs. It affects the quality of life, and many a times from the school the children will be sent back saying that you get the cure for this condition and then bring the child back to the school. How to describe that there is no cure for this? It's very difficult to counsel the patients. It generally regresses at puberty. This is a very difficult question to answer to the parents, because they'll be asking how many times we have to visit to the hospital and how many times we have to buy the medications and how long my child will suffer with this disease. It's very difficult to counsel. It takes some time to understand them, to make them understand the disease pathology and its course. Certain cases can evolve into atopic keratoconjunctivitis. See, the early phase reactions will cause some symptoms, but in the late phase reactions, it's very toxic to the corneal epithelium, and conjunctival fibrosis is seen in some chronic cases along with SPK, shield ulcer, vernal plaque, which can threaten the vision. These are some pictures wherein the typical perilimbal pigmentation and limbal papillae are seen in these children, and sometimes in chronic cases when the allergy comes down, there will be some large limbal papillae with some prominent vessels, which many times you will be confusing with the OSSN. And lower tarsal conjunctiva and also the upper tarsal conjunctiva has to be examined. That is equally important in all the cases, though the children will not be very cooperative for slit lamp examination. In chronic cases, some limbal thickening as seen here, they will have extreme photophobia. It's very difficult to take the clinical pictures like this in those children. There will be some cobblestone papillae, Horner Trunter dots, and lot of discharge in between the papillae and also the canthus. These children, the socioeconomic status also will be very low, and the parents and the children will not be concerned about the discharge and the hygiene, ocular hygiene. Atopic keratoconjunctivitis, as madam has explained, I will skip this, and some corneal complications like pannus can be managed, but shield ulcer, if it becomes grade 2 and 3, very difficult. And keratoconus we all are aware of, and every child has to undergo corneal topography as a routine ocular examination in every annual visit. In our hospital, we follow this protocol. Whatever the K reading is, whatever the topography is, the last year we do them. And limbal stem cell deficiency in chronic cases. Many differential diagnoses to this simple allergic conjunctivitis, and we all know how to differentiate them. And dry eyes, madam has talked about. Toxic conjunctivitis will be usually unilateral and sometimes bilateral, and there will be some inciting agent which we have to ask for the detailed history. And rosacea keratitis is intermittent and sometimes chronic, and not have any classical clinical pictures. We have to keep it in mind. And scleritis can have pain and glaucoma also. Flectinular conjunctivitis is also sometimes confusing because it causes a inflammatory nodule in the conjunctiva, and if the cornea is involved, there will be a small ulcerated lesion with a trailing leash of blood vessels. Management in the investigation part in these little children, it's very difficult to go for the invasive test, but the skin prick test is considered as gold standard. But the tear total IG and serum IG and eosinophil levels are done in these cases. The importance of it, we have to know which cases we have to ask for these tests is in seasonal and perennial allergic conjunctivitis, tear total IgE will be positive, and in VKC, total serum IgE levels are also very high, and serum specific antigen IgE test is also positive. Coming to the management, educate your patient very well. It takes a lot of time to counsel them and understand the disease, and ask the mother to control, avoid eye rubbing, and tell them how important the hygiene is. And slowly the children also should learn through the mother. Cold compression, very difficult because the children will not stay in one place, and avoid allergen exposure. And again, the difficult part because they always want to play outside, and plano glasses will definitely help. We prescribe them routinely for all the school going children who understand that wearing this glass prevents them rubbing from rubbing the eye. And we have to tell the parents and the school teacher also that child should wear the glasses all through the class. And the management algorithm for seasonal and perennial goes like this, which is already discussed about. Only thing is there are large numbers of antihistamines, mast cell stabilizers, and dual acting agents. In a nutshell, we can tell that most commonly used cromolons, sodium chromoglycate and olopatadine, and nowadays many other antihistaminics. Definitely sodium chromoglycate takes some time, some 6 weeks time to have the effect on the disease. So olopatadine is definitely helpful in acute cases, but for the maintenance, sodium chromoglycate will be better. It has to be given 4 times a day. And olopatadine different concentrations are available, starting from 1 time a day to 2 times and 4 times. And dual acting agents, in the newer agents, bipotastine, the drug is very effective in rhinoconjunctivitis, where the child will have the allergic rhinitis and the conjunctivitis also. Topical steroids, as we all know, we have to monitor the IOP and see for the cataract. And topical antibiotics in these cases, because the hygiene will be poor, to prevent the secondary bacterial infections. As we all know, cyclosporin and tacrolimus are the steroid sparing agents, and there are a lot of studies, and both tacrolimus and cyclosporin have equal potential to be used as first line drugs in vernal keratoconjunctivitis. And supratarsal steroids, again, in very little children it's very difficult, and can be given under sedation, and otherwise it can be given under local anesthesia. TR tacrolimus levels were studied, which drug is better, and all both are equally effective, and improvement was seen in tacrolimus patients, and it has proven its bioavailability in the TRs, and it's a very effective alternative method. And these are some potential advances in the allergic conjunctivitis. Many are not yet available in the market. They are all in the research process. And surgical management of sequelae, I am not going to cover in detail. If there are giant papillae which are disturbing the ocular tears film, then they can be excised, and mind it, we have to give it for the histopathology. And SLET for LSED, symblepharon release, and AMT for the symblephrons and occlusions in the secondary dry eyes. In the shield ulcer, as we all know, in the Cameron grading, in the grade 1, just the medical management with the prolonged use of topical steroids with the monitoring of IOP will be helpful. And in grade 2, it definitely requires debridement and AMT, and in the grade 3 also the same. And the pediatric dry eye disease, as it's all covered by the previous speaker, we all have to know vitamin A deficiency. Though there are some national programs for the vitamin A supplementation, we have to keep in mind there are still people who are living in the remote areas, they can have this. And lifestyle modifications, this has to be counseled properly to the parents. And we have to treat like adult dry eye disease in the same way. And chronic blepharoconjunctivitis, previous speaker has covered a lot about it. And rosacea keratitis, as I discussed earlier, it's very difficult because there will be no classical signs, but we have to see for the corneal vascularization and meibomian gland thickening, lid margin thickening and telangiectasias. There are some stepladder management for this. Azithromycin and erythromycin ointments are used in these cases. Marginal keratitis, they very commonly seen in the children, where we have to look for it. Some small corneal infiltrates with a lucid interval and corneal neovascularization has to be treated with the mild steroids. And coming to the last epidemic, keratoconjunctivitis, if it is involving the cornea, some things like subepithelial lesions, punctate lesions can be seen, and needs topical antibiotics and lubricants and steroids in very in the late cases and in severe cases. So the take home message is itching and watering is not always allergy. High suspicion is required to arrive at a probable diagnosis and administer appropriate treatment. Counseling the parents is vital for understanding the nature of the disease and the complications, and ensures the compliance to the therapy. Thank you for patient hearing.